Good evening, friends. I'm very happy to meet all of you this evening, friends both in India and across the globe. We warmly welcome you on behalf of the President of the IAGES, Dr. Ishwarmurthy, my senior colleagues, Professor Satish Mida, the National Secretary, Professor Randeep Vadhavan, the National Head of the Fellowship of Advanced Laparoscopic Surgery Board of the Indian Association of Gastroenteroscopy Surgeons. And he is also a very leading robotic surgeon from New Delhi, and he has a huge experience with bariatric operations. Friends, ladies and gentlemen, we have the honor of having two very eminent speakers for the evening. So let us listen to our president. Our president is traveling in to reach the Gatwick. We expect him to join him live in the session as a due course. Dr. Rajaram, can we have the message, please? Raja?
Yes, sir. Sir.
Yes, Raja. Raja, do you have any issues?
I think
Fine.
there's some
No
technical
problem, sir,
fault.
no problem.
Dr.
Ladies and
Randeep
gentlemen, Dr. Satish Mida, you can welcome and then we move on. Please, sir.
On behalf of IAGES, I welcome you all for this prime edition. We are having topics on the bariatric surgery today. And as you all know, that IAGES is one of the largest body of minimal invasive surgeons with membership crossing over 10,000. And we are having on-site activities throughout the year with many fellowship courses, both in basics and advanced surgeries, and also in endoscopic surgery. And today we have Professor Antonio José Torres from Madrid, Spain, who will be speaking on revision surgery for post-bariatric surgery, weight gain, and Professor Óscar González López, who will be speaking on new indications of obesity surgery. So I welcome you all both. And we have a PALS board chairman with us, and Dr. Kanagvel. So over to Dr. Kanagvel to introduce the guests so that we can start this proceedings. And Dr. Vadhavan will be moderating the session today.
Thank you, Dr. Mida. Friends, I have the honor of inviting Dr. Randeep Vadhavan to run the session for this evening. Dr. Randeep is also right now doing the fellowship program in advanced laparoscopic surgery bariatric division at New Delhi. This is the second day of the program. So it is more fitting to have the bariatric subspecialty talk happening together. So over to you, Dr. Randeep, sir. The evening is yours.
Thank you, Kanagvel, and thank you for that introduction. I have immense pleasure in welcoming Professor Antonio Torres. Now, he's someone who requires absolutely no introduction in bariatric circles. We all know him. We've all seen him operating, giving talks all over the world. But at the same time, I have a pleasant duty of introducing him. He is presently the Professor of Surgery at the University of Madrid. He's Chief of General and Digestive Surgery Services. His main area of interest, of course, is bariatric, metabolic surgery, obesity. He's into GI hormones, intra-abdominal infections, surgical oncology as well. He is a member of 28 national and international professional associations. Dr. Torres has authored or co-authored over 200 peer-reviewed journal articles. As principal investigator, numerous studies. He's been the president of SECO. Most importantly, he's been the president of IFSO, from in 2011 and 12. He's been the chairman of the IFSO's Board of Trustees 2015 to 19. And I had the pleasure of his invitation in Madrid in 2019 when he organized a fantastic IFSO, which was very well attended, and we all enjoyed it. Immense pleasure in welcoming you, Professor Torres, on your topic. And I must tell you, friends, that he's the inventor of the SADS, the single anastomosis duodenal ileostomy, which by and large, all of us are doing this procedure for weight regains. But he's going to talk to us on revision surgery, options on revision surgery. The podium is all yours, Professor Torres.
Okay, thank you so much, Dr. Randeep. And I like, first of all, I like to thank, the organization of the IAGES, for the nice opportunity for sharing with you, this important topic. And thank you, Dr. Satish, thank you, Dr. Randeep, and also Dr. Kanagabel, for allowing me, to contact me in terms of sharing, this opportunity. But for me, it's a pleasure. I have a lot of friends there in India. I remember when I was president of IPSO, my meeting was leading in Delhi. It was Pradeep Chaudhary was the president of this meeting when I was, the president of IPSO. So I have a very important memories there. I'm very happy to be here. And let me share my screen and try to to share with you some thoughts and some data regarding what I'm gonna be. I'm sorry. Okay, I'm gonna stop sharing because it's not the correct screen. Hold on one here. Okay, here we are. Here we are. Okay, so the topic today, I hope I'm sorry. It's not. Oh, why is this happening here? Okay.
The earlier slideshow is yet to be closed, Professor.
Yeah,
Please
I think I
close
have
the
to close.
PowerPoint and reopen the PowerPoint. That makes it
Yeah,
all.
I think I have to close that. Let me hope. I don't know why this is gonna be. Can you see now? Can you see my screen now?
Not yet, Professor.
Not yet. Okay. Let me hold on one second because I have another presentation here. Okay. And okay, hold on. Okay, I think 1 second. It's already check it, but anyway. Okay. Now, can you see?
Yes,
Perfect.
we can see your screen.
Okay, perfect. So my topic, going to be to talk about the revision surgery for post-bariatric weight regain or not having, enough weight loss. Okay, this is I would like to thank all you guys. The opportunity for me to be here, Dr. Randeep, Dr. Nagabel, and Dr. Sadeep, the opportunity to be there, and then this Indian Association West Indian Surgery going to be very important. So this is my disclosure, but most important disclosure is what we do in our Department of Surgery in Madrid. Here you can see, the share of our cases. We do a sleeve gastrectomy, approximately 44% of our cases, or by a first step procedure before to perform the studies, or as a primary procedure. Then we do the same percentage of procedure of studies procedure, one-way gastric bypass, and revisional procedure. As you can see here, we don't do in a routinary way one mini gastric bypass or one anastomosis gastric bypass, because we consider that it's more physiological to perform the anastomosis after the pylorus than before the pylorus. But anyway, we can discuss later on this issue. All the bariatric metabolic surgeons have our ambition is going to be to get in our patient a maximum weight loss, to solve all their comorbidities forever, to have no complication, and to have a happy patient. But reality in the end, it's gonna be you have some patient with insufficient weight loss and weight regain. We have some technical related complication. We already have some metabolic complication. Of course, our result, our aim regarding, getting the solution of the comorbidity. Sometimes we have temporary or mild response of comorbidities. So it's going to be my schedule, my agenda. What is the problem? Do we need a consensus regarding this approach, or what is going to be the therapeutic approach as in the end? The cause of the weight regain is very complex. Here is a very busy slide showing to you there are many factors depending on the patients. Here you can see before surgery, during the surgery, and after surgery, and there are a lot of factors affecting this matter regarding the outside the patient. Here you can see before surgery, after surgery, and post-surgery. Many factors that can contribute to the weight regain of this patient. Here you can see the definition of the insuficient weight loss or weight regain. Here you can see the classical criteria. We still don't have any other better parameter. Here the Reynolds criteria saying that is failure when we don't get a safe weight loss more than 50%, and here you can see a excellent result regarding more than 75%. All the Byron criteria and the Christo criteria are going to be very similar, one depending on the safe weight loss, another depending on the BMI of the patient. So there is no near consensus. What do we need the consensus? Here you can see, the last numbers of the SMBS, the American Society of Metabolic Bariatric Surgery, saying what is the most important procedure. You can see here that it's going to be a pandemic of sleeve gastrectomy. 61% of their procedures performed are sleeve gastrectomy. We can guess that some of them will fail in the future. We are coming in 2011 for 17% until 61%. On the other hand, the region-wide gastric bypass from 36% to 20%. We will focus mainly in those procedures. Fortunately, SADI procedure and BPDDS is going to be here, around 2% of the procedure, going to be the third procedure performed in the US. So, weight issues after bariatric surgery is going to be how to do or to deal with this therapeutic approach. The most important thing after a patient that is going to be with weight regain or not getting the appropriate or the desired weight loss is going to be to evaluate what was the primary operation of the best option. I think it's going to be very important to know what happened at the beginning. The initial BMI is very important. The metabolic profile of the patient at the beginning before the first operation. It was a patient or a surgeon's choice. Guys, that some patient or some surgeon, they decided that they only perform one procedure, and they think that this procedure is going to be suit all the patient. On the other hand, now due to the media internet approach, many patients are asking for one procedure, very focused on that. Was operation performed optimally regarding the bougie side, the twisting, and all the data, all the information about the first operation will be essential regarding making the proper decision regarding this issue. So, in this item, we have to revise and to check all the technical aspects of the surgical procedure, and we have to reevaluate this aspect. Here you can see regarding the sleeve gastrectomy, it's going to be very important how the bougie is going to be placed in the stomach, how to mobilize the complete fundus, how to deal with the hiatal hernia, how to start stapling very close or too close or too far away from the pylorus, and how we must avoid too tight stapling and to avoid twisting of the procedure. We face with this kind of sleeve, we must appreciate how this is a twist here, and this sleeve will not work properly in the future. We can face to the door this induced sleep. You must deal with this sleep in terms of treating the problem of this patient. But if there is no technical mistake nor complication, technical complication, what is the importance of the patient factor? Okay, I think the patient factor is going to be very important regarding this. We have to focus this patient after failing this weight loss or weight regain. We have to focus the patient and to put the patient under the multidisciplinary team in terms of trying to, by counseling, by introducing him in this multidisciplinary approach in terms of doing lifestyle modification, psychology, physical activity, and at the present time, medication. Medication is here for staying. I think, before improving at the same time, we are improving the compliance of the patient regarding modifying their behavior, modifying their dietary and their diet, and promoting exercise. But in the end, medication. Now here you can see how many different drugs are under investigation regarding this issue. And recently, here you see the three more important that you are using in clinical practice are mainly GLP-1 agonists, semaglutide, the association of GLP-1 and GIP receptor is the tirzepatide, and cagrilintide going to be very important. Here you can see, and here you can see the very important trial published in New England Medicine in 2022, regarding in this trial was association with glucose dependence receptor polypeptide, GIP, and glucosilipeptide 1, GLP-1. The association of these two receptor agonists, of these two incretin hormones, have produced a very important result. Here you can see if we implement this medication once weekly, tirzepatide, we can get almost 20% of weight loss in this trial. So it's going to be an important tool we have in terms of fighting or controlling or trying to control this weight regain of this situation. Here you can see a personal patient we had in our department. Sorry, because it's in Spanish, but it's a woman with 73 years old. We're operating on her, when she was 53 years old, and then we do a one-way gastric bypass, and then the patient regained weight. We put her on metformin, and then we implemented her GLP-1 analog, and now she's 73 years old, and her weight is going to be 67. Going to be the way of dealing with a failed one-way gastric bypass in this patient. It's going to be a very important tool to use in this issue. But in the end, if we, after trying all of these medication and the end evaluation by the multidisciplinary team, we don't have any solution, we can think in working in making the decision of operating the patient. So what will be the different options performing the revisional surgery? There are many surgeries. One focus, as I mentioned before, in the sleeve gastrectomy at the first, and then we have what is going to be the different option for dealing with this topic. There are many different surgical alternatives if we have to operate this patient. We can band, the sleeve. We can do re-sleeve. You can plicate the sleeve. You can convert in one-way gastric bypass, in mini gastric bypass, one anastomosis gastric bypass. We can convert the sleeve in duodenal suite, standard one-way duodenal suite, or we can do a standard BPD, or we can convert the patient in SADIs, SAGIs, transit bipartition, SASI, and probably I'm forgetting some of them. This is debate regarding that. Want to be, generally speaking, after this failed first operation, we can add a restriction or add some hyperabsorption. I think we can delete of our brain the word malabsorption, because we are not performing anymore any anastomosis so close to the ileocecal valve. And here you can add restriction. We can do it endoscopically. We can do the Ross procedure, the Apollo procedure, the POSE procedure. We can plicate endoscopically, or we can implement endoscopically or surgically, or you can implement, the lap band adjustable or non-adjustable, that to add restriction to this patient. Or on the other way, we can add some hyperabsorption. We can convert the sleeve gastrectomy in Roux-en-Y gastric bypass in one anastomosis bypass, or to convert in DS studies. Let me talk about that, focus that, in this paper coming from Doha, from Qatar. The Dr. Salman Al-Sabah, he published the role of red sleeve with a very short period of time. 12 patients underwent laparoscopic Roux-en-Y gastric bypass, and 24 patients underwent red sleeve. I think the result are 1 year result are going to be very promising, but only very short follow-up. When we have to think in converting a sleeve gastrectomy to Roux-en-Y gastric bypass, this is all the paper, and there are no huge paper regarding that, but we will with that later on, having no very nice excess weight loss, medium and long term. And here you can see the revision. This one will be probably the most important paper dealing with this topic, converting rigid gastrectomy to Roux-en-Y gastric bypass. The 10-year result. This paper is coming for Professor Prager from Vienna, showing us a very important result regarding this issue. Here you can see 10 years, the total weight loss is going to be after only 52% of the weight loss 10 years for converting the sleeve gastrectomy in Roux-en-Y gastric bypass. Very poor result regarding this issue. And then we have another alternative, going to be all these pylorus preserving procedure. When I'm talking about that, I'm talking about the standard studies or the duodenal jejunostomy. Going to be this kind of procedure are going performing in your part of the world, maybe in China, in Taiwan, Japan. It's going to be what I mentioned as proximal studies is anastomosis between the duodenum and the jejunum. On the other hand, the studies in the duodenum and the distal ileum. In this approach, how we work much to convert the sleeve in another procedure. Why not to maintain the sleeve intact? Because the sleeve is good. Take advantage of this, because in preserving the sleeve, we are preserving the anthropyloric area, as you will see later on. In this way, we don't have biliary reflux, and we are preserving the secretion of many important substances. We can preserve chloric acid secretion, pepsin secretion, gastrin secretion, intrinsic factor secretion, and improve the absorption of many other products. Here you can see our first paper published in 2014. Our first 18 patients, how they were very nicely at the beginning, after sleep, then worse, and then after study procedure, getting a very nice result. Then later on, we updated our result in 51 patients, our result 5 years after the conversion of this after failure sleep. Here you can see how we can perform the procedure. We perform the procedure in an American position, and we are operating this patient on the left side of the patient, because we don't need to deal with this sleeve upwards. We already checked the sleeve. The sleeve is going to be nice. We do CT volumetry in terms of calculating the volume of the sleeve, and then we are working now in a very virgin, a very don't touch area. You're going to be after the sleeve. The sleeve is upwards, and now we are dealing with the stomach here, and we do the dissection, in a very non-touch area. You're going to need to facilitate the procedure in these kind of cases. Here you can see how we can dissect that, and then we dissect, here you can see the pancreas, this is the duodenum here, and then we pass a tape or a Western loop, like in this case, in this duodenal dissection. And again, to point it out, to underline how important it is to must work in a non-touch area. Once we already dissect the duodenum, the most challenging part of the operation is already performed, right? And we increase a little bit and then we put the stapler as distally as we can, in terms of preserving as much duodenum as we can. one we already fired, you know, the stapler. We already have performed, you know, the most, I would say, challenging or important part of the operation. That's all. And now we have to look for our, we put a stitch here in terms of avoiding twisting later on. And then we go to the iliocecal valve, and then we count upwards, knowing the common channel, 250, our standard, is our standard length of the common channel, but we can increase if the patient, you know, is suitable for that, to 300 of everything. And then we pull up, you know, this ilium, and you can see here there is no tension. The ilium is bringing up in a very nice way. We use bar-based suture 3.0. We do 2 layers, and then we do that in a very nice way, where, you know, opposing a small bowel with a small bowel. One is called duodenum, the other one is called ilium, but it's very nice anastomosis with no tension, very nice blood supply. We do a 2-layer. Here you can see we use a bar-based suture. This is the anterior layer. And then, you know, we do the final and second layer with the interrupted PDS 3.0 stitches in terms of avoiding tension and to have a nice appearance of the procedure. Okay, we as I mentioned, during 2020, we updated this data regarding 51 patients. Here you can see the numbers, very mirroring excuse me, the previous result I just showed you some years ago. And here you can see after the sleeve, the patient did well, then worse, and after the sleeve gastrectomy, regarding the cell weight loss, the total weight loss, at the BMI, and everything. When we go deeper in this result, we realize that the patient that had a BMI less than 50 at the beginning of the procedure did much better than the patient with BMI, higher BMI. And the patient we reoperated later, more than 3 years after the operation, did much better than the patient operated earlier. And the patient that responds very nicely to the sleeve going to be much better than the patient who respond not so well to a sleeve gastrectomy. It means that there is a direct relationship between the weight loss after study 1 year and the weight loss after sleep. This is a linear correlation between these two situations. It means that we thought at the beginning that performing one-shot surgery is much better than to do in 2 steps. But in the end, 5 years after the operation, we realized that the results are very, very, very similar. This experience has been reproduced in other groups. Here you can see the figure for Dr. Cotton from Utah in US, showing us, how we're going to be in the end very similar if you in 1 shot or 2 shot the result, long-term result. And here you can see one of the most important papers, I think, regarding this topic is going to be comparing Roux-en-Y gastric bypass and SADIC procedure after failed sleep. This is a paper published by the Netherlands guys in Holland, the Netherlands High in Europe, maybe a multi-center study showing that if we operated the patient after failed sleep and we submitted them to a sleep gastrectomy, to a Roux-en-Y gastric bypass, you did total weight loss after 5 years. If you submit the patient to a Roux-en-Y, they only will get 7% of total weight loss gain, comparing with the total weight loss that they had at the beginning before implementing. On the other hand, the patient submitted to SADIC procedure is going to be having a 26% the weight loss in this case. It means that the Roux-en-Y patient going to be very close that the total weight loss they had before submitting them to Roux-en-Y gastric bypass. And we focus, we go deeper in this result, we can realize that the Roux-en-Y gastric bypass in this patient have been performed with a very strong, biliopancreatic limb, 150 centimeters. And the SADIS procedure were performed with 250 centimeter comma limb. Going to be the more aggressive in brackets, in inverted commas, SADIS procedure with the more aggressive, in inverted commas, Roux-en-Y gastric bypass. In this paper, when we focus on the nutritional deficiency, there is no differences between Roux-en-Y gastric bypass and SADIS procedure. And here you can see regarding hemoglobin, calcium, phosphorus, ferritin, albumin, all the parameters are going to be no differences, except, of course, regarding vitamin B12 and folic acid and some micronutrients for sure, because in the study we preserve more stomach than the Roux-en-Y gastric bypass. That's a very good piece of information that in this case, there is no differences between regarding the nutritional deficit between the two groups. Here you can see the demographic data of this paper. 66 patients were submitted to study due to insufficient weight loss, and 78 to Roux-en-Y. Some of them, 40% of them, due to functional problem. It means GERD. And the conclusion of the paper that they're going to be conversion of sleep to SADIS leads to significantly more total weight loss compared to Roux-en-Y gastric bypass surgery, with no differences in quality of life, scores, complication rate, or micronutrient deficiency. When GERD is present, there is no doubt that the Roux-en-Y gastric bypass is going to be the best option. We already compared, what is the role of converting a sleeve in one anastomosis gastric bypass. We did this work with Professor Marcus Reisis in Germany, Dr. Martin Bussen, and ourselves, Dr. Martin de la Cruz. We compared in this paper 42 patients after failed sleeve to SADIS and 42 to one anastomosis gastric bypass. We found 3-year result a little bit better, with no significant differences between regarding the total weight loss and regarding the said weight loss, a little bit better for the SADIS procedure. But the most important finding of this study were regarding the adverse events in this population, and mainly, the symptomatic bile reflux. Symptomatic bile reflux was observed in one anastomosis gastric bypass patient in 26%, and in 5% regarding the SADIS procedure. A very important piece of information we got from this study. In this Delphi analysis, this approach we published in 2019 regarding what is the best therapeutic option for weight regain or insufficient weight loss after sleep, rest sleep or Roux-en-Y gastric bypass was, thing if the first sleep, as you saw in the previous slide, is not very well performed. It's a dilation, hiatal hernia. We can think in rest sleep and do a Roux-en-Y gastric bypass. But if the problem is insufficient weight loss or weight regain, this study was this procedure got the most important consensus at all. In a recent publication, published in 2022, studies has been showing that this weight loss is going to be after all the different restrictive procedure. I mean, banding, vertical banding gastroplasty or leg gastrectomy, SADIS and DS are going to be the most important regarding total weight loss, and total loss after follow-up is going to be after 1 year, after 3 years, are going to be considered the most important option for failed restrictive procedure in this paper. A recently publication regarding the differing option for the weight regain or weight loss after a sleeve gastrectomy. Here you can see that the most important are going to be the DS and SADI, going to be the most important result, even 3-4 years or more years after the procedure, regarding the BMI after revision. There are other procedures, gastroplasty, Roux-en-Y gastric bypass, are not doing so well as you can see here. And then, regarding the other important procedure, Roux-en-Y gastric bypass, what can we do after failed Roux-en-Y gastric bypass? Weight regain or not losing enough weight? There is no important data regarding that. There is no much data in the literature. Here is a recent review published in 2022. Here you can see the different approaches regarding the BMI during the follow-up. That surgical procedure, I mean, resizing the pouch, doing a banding, doing Roux-en-Y gastric bypass or DS. All of them can get a very important result, but there is no doubt that the standard DS or SADIS procedure, you're going to be getting the better result. There are some other endoscopic procedure, that is the Apollo procedure, the Argon procedure, you're going to be getting very, very poor result in the end. You're going to be a very challenging issue in this end. So there are another option. If we cannot do nothing surgically, we can be more radical in terms of getting to transplantation at the brain of the patient. Going to be very radical. It's a slide courtesy of Dr. Brunner Delemans. So here you can see a very important approach. It's showing to you what's going to happen if you offer Roux-en-Y gastric bypass, or you offer Roux-en-Y bypass or sleeve gastrectomy. If the patient has a BMI less than 40, the chance of the probability of being still maintained obese is 5%. But if the patient has a BMI of between 40 and 45, after sleeve or Roux-en-Y gastric bypass, the chance of still being obese is 40%. But if the patient's BMI is between 45 or 50, the chance of still being obese is 70%. If the BMI of the patient is more than 50, 95% of chance after Roux-en-Y or sleeve gastrectomy is going to be obese. So the measures to take home in this case is don't offer at the beginning, in a patient with more than 50% Roux-en-Y gastric bypass. You can offer a sleeve because you can wait and see, and if something failed, to convert in a SADIS procedure later on. And that's all, my friend. Thank you very much. I'm stop sharing my screen, and I am more than happy to have your question or your comments.
Thank you, Professor Torres, and I think it was a wonderful talk. Yes, there would be some questions coming in. Let me see if there are any questions from the audience. Meanwhile, I'll start with some of these questions. So you said as a primary procedure, more than 50 BMI, you would offer them SADIS as a primary procedure as well. Would that be the case?
Yeah, that's right. More than offering SADIS, I think it's going to be the ideal situation. The message is going to be, Dr. Randy, on the contrary, don't offer them a Roux-en-Y gastric bypass, because the chance of failing is so high. Because we already had the experience of the American guys being performed Roux-en-Y gastric bypass for 50 years, 55 years, 5 years, and we have the information that almost 30% of them will fail. It means 1 after 3. I think in this situation you can offer them SADIS at the beginning, or to be in a step-by-step procedure, to offer them a sleeve if the patient is too complicated, is too challenging, and then wait and see if the patient is not doing well, to do a SADIS procedure at the second step.
And is your sleeve different in a SADIS compared to what you would do as a primary sleeve gastrectomy? Would that be a different sleeve, or would it be a similar sleeve?
Well, when we perform a sleeve gastrectomy as a primary approach, we do a narrower sleeve. In terms of getting, we are using a 54 Rouilly, 18 millimeter Rouilly when you do the SADIS procedure, not adding important restriction and important absorption at the same time, the same day, in the same patient. But when we are thinking in doing sleeve gastrectomy, we're using a narrow Rouilly, a 40 Rouilly, 40 Rouilly. But in the end, when you must reoperate the patient, this sleeve is going to be dilated a little bit. It's going to be, in the end, going to be not so restrictive as it was the first time.
What we've seen is in our own practice as well, and that's what the data says, that in a sleeve patient who's regained weight or inadequate weight loss, in those patients, re-sleeve or RYGB never works. RYGB, you may still do it for patients having post-sleeve GERD, but by and large, for weight regain, this just doesn't work. We need to have a hypoabsorptive procedure. Now, OAGB is something which is being practiced in India widely. SADIS, for the only reason that it's more aggressive procedure, it's something which causes more malnutrition, is something where people are a bit skeptical about doing it, particularly when you look at a common channel of, let's say, 200 or 250 centimeters. Ideally speaking, in Indian patients, you would want to leave at least 400 centimeters of common channel, because the kind of protein intake that they would be taking. And that's why more commonly it's probably a sleeve DJB is what is done, or a sleeve converted to an OAGB is what is done, as compared to SADS. Your comments on that, please.
Yeah, Durandip, yeah. I don't agree regarding, the OIGB, one anastomosis gastric bypass is going to be less hyperabsorptive than the SADIC procedure, because the OIGB in the end is going to be depending of the length of the common channel at the end. The OIGB is going to be a more restrictive procedure. You are not maintaining the sleeve, right? Regarding this topic. And if you use a biliopancreatic limb more than 250, or the biliary limb is going to be, OAGB is going to be as malabsorptive as SADIS procedure. I don't agree, the OAGB is less hyperabsorptive than the SADIS procedure. It's as absorptive as a SADIS procedure. But you are completely right. In your region, in India, Taiwan, China, Japan, the proximal SADIS it makes all the sense. The data for Dr. Kasama from Japan, Siki-1 from Taipei, from Taiwan. Now he moved to another city, to Taichung, and the data of those guys is a proximal SADIS. In the end, it's a duodenal jejunostomy. Counting from the trace angle. I think it makes all the sense, because two reasons. One is you are maintaining the sleeve and the antrum and the duodenum, and you are doing a very more longer common channel if you are counting from the trace angle. But I don't agree in your country. I know that the one anastomosis gastric bypass is very widely performed, but I don't think it's going to be less aggressive than the SADIS procedure. On the contrary, I think it's more aggressive. You are not maintaining the antrum, the pylorus, and you are doing a very hyperabsorptive procedure. And for sure, you are having some nutritional problem with your one OAGB or mini gastric bypass patient in your country.
And more than they have those problems as well as dumping as well. So if you leave the pylorus intact, you have much less dumping as compared to the OAGB procedure.
Marginal ulcer, Randy.
Marginal ulcers.
Marginal ulcer. All these symptoms, if you avoided the antrum and the pylorus, you will face with this kind of problem, without any doubt.
So another thing, couple of points regarding just the procedure per se, just the way you do that procedure. One, when you're doing the revision, would you a dilated sleeve? Would you staple on the dilated sleeve and make it narrower? That's one, an answer on that. And two, when you fire on the first part of the duodenum, do you oversew it to prevent a blowout on that duodenal stump? So two aspects on the technical aspects.
Thank you. Very important. It's a very important question, Dr. Randev. Very important question. Regarding starting for the second one, we don't oversaw nothing. We learn in our practice. We are coming from operating patient after a very tough duodenal ulcer in the past. Do you remember? In those cases, duodenum was very, very fibrotic, very, tough, a lot of inflammation there. We thought, to do a push string, even many things there. And then we learned from them that now we're going to be very important, don't touch anything there. The secret, the strategy is to go as far as distally as you can, as very close to the pancreas. In this sense, all the blood supply of the pancreas, the superior and inferior pancreatic vessel artery coming from the gastrointestinal artery are coming irrigating this area. So we don't touch that. We don't do nothing in the duodenal stump. We haven't had any problem regarding any blowout, with this duodenum. Regarding the other aspect, when we perform SADIS after a sleeve, we don't do at the same time, following the Nicolas Capinaro, principle, don't add at the same time, restriction, hyperabsorption in those patients. we study all our patients with CT volumetry. If the CT volumetry, the volume of the sleeve is more than 300, we consider this sleeve is not able to perform. So you have to think in terms of dealing with the badly performed sleeve or the SADIC procedure. We prefer to do, we have some cases, we do both at the same time, but we were not very happy with this approach. So we prefer if the sleeve is, partially dilated, we prefer to do the SADIC procedure and, forget about the sleeve gastrectomy, and then we'll see. If as the time goes by, if we need to re-sleeve, we can do that later on when the SADIC is implemented. But very, very few patients, one or two, no more than one or two, have been needed to do re-sleeve after performing the SADIC for failed sleeve.
Okay. Another thing you mentioned regarding the anti-obesity medications. So it's something like, we call it the sleeve plus, give a sleeve, and then add plus. Plus doesn't mean you add another procedure, just give the anti-obesity medications. So you're mentioning the same. So they've come in India as well. We don't have the injectable semaglutide as yet. We only have the oral one, but probably in another few months, we will have the injectables as one. Now, the issue with these anti-obesity medications are they last only till the time you're giving them, and they come at a reasonable cost. As soon as you withdraw these, that's where the problem starts to happen. Your experience on these?
Yeah. The problem here in Europe, in Spain, is very similar in the US as well. The medication is here for staying because, it works. But the problem are two different challenges regarding the anti-obesity medication. One is, for how long must the patient have to take the medication? We don't know. We have a trial, regarding 2 years, 3 years, and no more. It's a very limited experience regarding what's going to happen with the long term. And the second, as you already very nicely mentioned, is regarding, the price, how the patient or the society or the health system in Europe. We have the national health system. In Spain, all the medication have been, supported by the national health system. How can we afford to pay so huge quantity of money regarding for how long? We don't know yet. There is no when. And the third issue is going to be what's going to be the fidelity of the patient with the medication. We know that the patient are not very well controlling the adhesion to taking the medication, this injectable medication every day, for how long, I think. But anyway, I think we have to think about that, mainly in terms of avoiding to indicate surgery if this medication can allow the patient and the doctor to, reorder or to reschedule the plan of the patient is going to be important. The medication is going to be a very important tool for the patient in this issue, especially after Roux-en-Y gastric bypass, where the surgical options are not as as nice as after sleeve. After sleeve, we have studies working very nicely, but when a Roux-en-Y gastric bypass fails, it's going to be a different issue. This is my comment on the beginning, Dr. Randeep, that if you have a very heavy patient, a very metabolic patient, don't offer him or her a Roux-en-Y gastric bypass.
Absolutely agreed with you. So we can keep discussing, but we have Professor Óscar waiting for us and with this talk. And thank you very much, Professor Antonio, for this fantastic talk. We've enjoyed it. And like I said, we can keep discussing all day long, and you'll just need to move on. Thank you so much for joining.
Absolutely. Take care. Have a nice day.
Thank you.
Bye-bye.
Thank you.
Bye.
Thank you, Dr. Thank you, Dr. Randeep. Professor Torres, I have one quick question to be asked to you from the main platform. One of the guest delegates asked me to forward his question to you. After this RDAS procedure, we have seen you updating the data of 5 years follow-up and as well with large number of patients. And how do you manage to follow this patient for micronutrient failures, or how do you follow this patient? He would like to listen to your department's protocol briefly, Prof.
Okay, I think I usually say that our most important supporter for the SADI procedure patient are our endocrinologists. Even now they are pushing us, in performing more and more SADI procedure because they are observing the evolution of the patient during the follow-up, and they are so happy with this kind of patient. So the secret is we have revising the patient between the endocrinologist and surgeon at the beginning, the first year, every 2 months, and then we follow the patient every year and for life, and then depending on the patient, because it's very important regarding this hypersalty procedure to identify the metabolic problem, the nutritional problem, as early as we can. We already learned at the time went by during the last year that we have to modify our supplementation scheme. I mean, we increase the doses of calcium and vitamin D because we observed at the beginning that they going to be a problem regarding the osteoporosis in the woman and the pseudo hyperparathyroidism, regarding the low calcium level. Or we increase the doses of calcium and vitamin D. We already including in our supplementation the micronutrient copper, zinc, selenium, because we already knew, we learned during the last year. Now our supplementation is very standard. There are several companies. I think I don't want to mention any commercial name, but there are some companies that are adapted. They already adapt their medication to the needs of the patient after studies or duodenal switch, increasing the doses of calcium, vitamin D, almost double the double of the standard one-way gastric bypass, and implementing some micronutrient agent. Calcium, copper, because we already studied these nutritional issues in our follow-up. But the secret, our follow-up, Dr. Kanagavel, is going to be very important. Our follow-up is going to be approximately 75% 10 years. We know what happened with our patient of 75 over 100. It's going to be very important issue because in this way we know what is happening with our patient. If you cannot follow your patient, but I don't care, it's going to be SADIS or Ruan-Y or AGB or whatever you want. You must follow the patient because, as I mentioned with Dr. Randip, I think there is no. I disagree with the affirmation, with the sentence that AGB is less aggressive than SADI. On the contrary, I think it's more aggressive because you are not preserving the stomach and you are performing a more hypersalty procedure or AGB than with SADI procedure.
Well said, Professor. I would like to listen to Professor Óscar González. And first of all, I should thank Professor Óscar for kindly recommending you and getting your acceptance for the invitation. Dr. Óscar and myself are known to each other for more than 17 years now. And I visited his center long back in 2009, and he's been kind to host us during that time. And since then, we have been crossing each other at multiple forums. Dr. Óscar, now that you have listened to Professor Torres for the last 30 minutes, what is your quick comment before we move on to your talk?
Hi, Oscar. How are you?
Hi, Antonio. How are you? I feel,
Good.
Antonio, that talking after you is like I am selling ice in the North Pole. because you have
Don't
to
say
know
that.
yes, but
Don't
you
say
have to
that.
know
You are
that
extremely important, for us. Oscar. Take care.
And Antonio was my professor during the resident period. He is my inspiration still. Sometime when you are in bad moments in the OR, and I learned a lot of his personality and the way he managed the problems. after many years working together, I can see that he is one of the more important references in surgery in obesity and esophagogastric surgery in the world. I'm very proud of this. Okay.
I'm very proud of you, Oscar.
Thank you, Antonio. Thank you very much.
Dr. Randeep,
Okay.
I think you can introduce Professor Oscar and then we move on to listen to his talk. And Professor Antonio is going to stay with us. He has committed and he has made himself available for this program for say. So we'll be able to listen to Antonio's, Professor Antonio's comments as well after Dr. Oscar's talk. Over to you.
So I have immense pleasure in welcoming Professor Óscar González. He is the head of endocrine, bariatric, metabolic surgery at the University of Barcelona, Spain. He's been a member of multiple societies, IFSO, SECO, and so many others. He's been a reviewer for 3 index journals, and he's a member of the board of directors of the Spanish Society of Obesity Surgery. He's going to be speaking on the newer indications for bariatrics, for obesity surgery. It's going to be very interesting, and we look forward to hearing your talk. Professor Óscar, please.
Okay. Do you see the screen now?
You can share your screen.
Yeah.
No, we can't see your screen.
Yeah.
We can't.
Okay. Now?
Not yet.
Not yet.
Not yet.
Not yet.
Okay. Okay. Yeah. Not. Yeah. No. Sorry.
Recording in progress.
Now?
Yes, we can see your screen. You can just, we can see that.
Yeah. Okay. That's it. Well, I have to talk the newer indication in bariatric surgery. That it's we are in a key moment to understand that surgery is for the moment the only true treatment for obesity, for a disease called obesity that we don't know the etiology, the true etiology of the disease. Okay, we know that it's a chronic and relapsing multifactorial disease in which the accumulation of body fat promotes adipose tissue dysfunction is a new epidemic in the 21st century, affects all the country, all the world, and is leading the cause of non-traumatic death in adulthood. There are many obesity techniques. Here, I can put in first time the studies that, as Antonio talked, and the importance of maintaining the pylorus. There are other many interventions that I think that the future is in maintaining the pylorus in the body of the patient to avoid problems. Sometimes you can have any other problems, but the biggest of gastric bypass or many other procedures you can avoid using properly. I want to say that when you perform obesity surgery in the patients not only live better, if not the patients live more time, and this is important even for the national security system, because in a long time period, the cost of obesity surgery is much beneficial for this system, because the lack of problems of myocardial infarcts, strokes, traumatic problems, etc., etc. So, two concepts I want to let clear: that the patient lives more and better, and is beneficial for the system, the national system at long time. But okay, we all know that this is not the politics looks after, and probably they don't consider to in the future. I have to say that the classic indication of obesity surgery was made in a medical magazine, Annals of Internal Medicine, in 1991. It was BMI over 40 and BMI over 35, and comorbidities and diabetes, hypertension, dyslipidemia, arthropathy, venous insufficiency, etc. But for last year, the both most important societies in obesity, the AES, BMAs, and the IPSO, elaborate a new update for the treatment of patients. When I talk of obesity, they consider that in Asian people, when we talk of 30, in Asian people should be 27.5, should be of obesity surgery of the obesity. This is the paper you can see from the SOAR, from the HBS, and the other one was the IPSO paper. First, I would like to talk about the contraindication of obesity surgery, and I have to say that there are not absolute contraindications, but always related contraindication relative, partial contraindication is the patient that is suffering active disease like a cardiac failure or unstable coronary fatigue and pulmonary insufficiency, inflammatory bowel disease, overall Crohn's. The patient is under an active cancer treatment, but consider that one of the indication would be a reduction of toxic doses if the patient has to receive a second cycle of one type of chemotherapy. The most common contraindication is alcohol or drug dependence. Overall, alcohol is the cause of failure more common after a long time period. Mental retardation is not a total contraindication, but the patient should understand that the procedure and the guides he has to follow. Overall, of course, if a contraindication to general anesthesia, but we know that there are many colleagues that can perform this surgery under regional anesthesia, and this is not total contraindication. And the last one is patient under unstable psychopathy. It should be considered that 2 years of psychopathy stability necessary to perform obesity of surgery. This is the global point of view of the current indications. If we can operate it on in the left hand, all the BMI over 35, and we can operate it on the patient over 30 to 35 if they have one of the following comorbidities: type 2 diabetes, dyslipidemia, hypertension, venous nicotine, etc., etc. But I want to point you that there are two that is decrease in quality of life and unacceptable psychological state after trying all the ways to lose weight. We are currently making 3 studies in the recruiting phase that in the value of obesity surgery, NASH, in steatohepatitis, polycystic ovary, and type 2 diabetes. The new indications you can see in 3 ways: benefits from ponderal loss, metabolic benefits, and associated to the pathology of obesity due increase of weight. Benefits of ponderal loss and the big weight is intracranial hypertension, and benefit from ponderal loss are hernias, and you can consider a benefit like aesthetic improvement. In the other way, the metabolic benefits are in the steatohepatitis, the polycystic ovary, and diabetes, and increase of and improve of diabetes type 2. And associated to the pathology of obesity, the case of weight, is the orthopedic surgery, sometimes of arrhythmias, the mix of all the three points is liver transplantation, renal transplantation, and the surgery in advanced age. We all know that the metabolic surgery in patients between 30 and 35 kilograms square meters are very important. Really, we consider more honeymoon that a curative procedure, but this honeymoon could be eternal, could be sometimes 20 or 30 all the life that threats to the patient, and this is more important. We have to identify which of them are to be to have benefit of performing a procedure. This is an schedule from Rubino, but I think it's a little old. It's getting older because currently we consider that all the patients with diabetes type 2 can be benefited from surgery of obesity. Of course, they have to change the lifestyle, and they can use new medication, but due to the levels of safety of obesity surgery currently, it's an option, if not mandatory. Respect to arrhythmia, some cardiologists and as patient that has prolongation of QTc, that patient has the potential ventricular fatal arrhythmias and are very good candidates to lose weight. To rapid loss weight is an important loss weight like surgery of obesity can provide. This is two papers that you can read, but the prolongation of the QTc and of the QTc is a good indication for this surgery. The polycystic ovary syndrome, you know that is the same disease as metabolic syndrome. Is that you know? Do you remember that people with hair and touches in the skin, loss of hair, colored skin, cutaneous tag, and overall cyst in the ovary and infertility. In Europe, polycystic syndrome is the most important cause of infertility, and the real cause is the malfunction of the receptor of insulin substrate in the hypothalamus that origin and abnormal gonadotropin levels, and this dysfunction makes the ovary not to permit not to finish the ovulus and make a cyst instead of a fertility ovulus, and this make this origin also an hyperandrogenis, that is the origin of many of the skin problems, and the follicular arrest that origin the cyst in the ovary. We suggest that the obesity is disease that is based in the malfunction of the receptor of insulin substrate that is going to work bad, and the rest of manifestations like alteration of GLP-1, adipokines, and so on hormones that are in obesity are secondary and a consequence of this malfunction. So talking about pharmacs, they have to work in the etiology of obesity because like they are only treating one of the hormones as they are a consequence, they never will cure definitively obesity, and its functionality will be only partial. Well, there are papers about the benefits of obesity surgery in polycystic ovary. As you can imagine, is the same in steatohepatitis. In fact, the liver cirrhosis due to steatohepatitis is the main cause of transplantation in the United States, and also I think that currently in Spain. But the question is the same. It's the insulin resistance in and its representation in the liver. Is from 2018 that we all know that obesity surgery can prevent the progression of steatohepatitis, and is a good treatment to avoid a bigger problem. But the question is if obesity surgery will be able to reduce fibrosis. We are talking a lot about insulin resistance, but what is insulin resistance? We can measure using the HOMA insulin resistance. That is this is a simple formula: insulin per glucose, and this is the 20% of. But the insulin resistance can be measured more precisely by the formula registered by Cambridge University. You have to know that the most potent method of lower the HOMA in any patient is the obesity of surgery, the surgery of obesity. Gastric bypass can lower the HOMA from 10 to 1, sleep from 5 to 1, and medical therapy, diet and metformin only 5 to 3. And most potent is gastric bypass and SARIs and gastric duodenal switch, that is 14 to 1, and this can be read in the paper of Philip Sauer in the New England Journal of Medicine of 2020. Obesity as preparation for other procedures. You can see that in the transplant, in the liver transplant, it's not clear, but in some institutions like Mayo Clinic, they perform gastric vertical gastrectomy together with liver transplantation, but is the only center I know that they perform at the same time. But most of the time, the recommendation is perform a sleeve gastrectomy after the liver transplantation. But you have to know that the major complications are over 20%, and mortality at 1 year is an 8%. But you have to think twice before you perform. And it's more clear that in kidney transplant that you can perform before making a sleeve gastrectomy, or you can perform after the kidney transplant, performing a gastric bypass or sleeve gastrectomy, depending on the condition and requirements of the patient. Obesity surgery is also the treatment of pseudotumor thyroid hypertension, cranial hypertension is a syndrome due to the endocranial pressure in the absence of a causative factor and without the enlargement of cerebral ventricles. There are not also vascular lesions. There are many papers that recommend the surgery of obesity in this case. We have a case of a 48 years old woman that was diagnosed of cranial hypertension. It had lumboperitoneal shunt at 14 years before. The shunt has a migration. The patient developed clinical of headache, diplopia, and photopsias. The cranial tension was 40 millimeters, and its BMI was 31. It was many years ago, before the approbation of IFSO and SBS, the new indication. We perform gastric bypass and remove the catheter, the lumboperitoneal catheter. The patient recovered completely. The patient recovered completely and is currently free of disease. One of the consideration we have to do is the surgery in extreme age. Overall, children or teens is a safe and effective surgery, and the adolescent benefits of the weight loss and improve all the comorbidities. The surgery in this patient is very, very effective. And in the age, I have to say that the first time I operate on patient with 73 years old was a little scared. Now he is 81 years old, and every year come to see me and give me a kiss and to tell me it's the best thing I do in my life. And so, if possible, age is not question to perform the intervention. The patient with abdominal wall defect with hernia has a 30% of probability of relapse of the hernia after repair if they are the diagnosis of obesity. So the current indication in all centers, in many centers, is first is correct the obesity, and when the obesity is corrected, perform the intervention of the defect abdominal wall. I have to remember that there are some rare disease and some problems difficult to resolve, like the Prader-Willi syndrome, that affects 1 of 10,000 births. Is the first genetic cause of obesity. If the boy is look normal until 12 months, that develop an hyperphagia, and this is incredible the gain of weight that the boys had, that is, increased the weight day by day, and even performing surgical procedure that should be always malabsorptive. All these patients died very, very young, if 14 or 20, less than 20 years old. That's Prader-Willi syndrome that should be studied and keep in contact. There are another special situation that's psychiatric disease, patient with cirrhosis, patient with immunodeficiency, a patient that needs a second cycle of probably second cycle of chemotherapy, patient with renal failure or overall at the beginning of the renal failure, immobility, patients that are in the wheelchairs, and reduced surgery that Antonio has told enough. So this is a scheme of work now, like primary treatment, the treatment of the weight loss, and the treatment of complications, and new approach of weight. Antonio has told a lot of very, very well of the surgery. I don't insist more. I want to say that the robotic surgery is here to stay. When talking about robotic surgery, I want to say that it's not only one robot. That now we have, we can use different robots, and they are here to stay. I love the robots, but they have to improve, to offer a big difference between the current laparoscopic procedure and robotic procedures. But keep in mind that the future is here. That is the evolution of the Da Vinci system. As I told you, now there are many other robots. This would represent the future of surgery 4.0. And that's all. Thank you very much. Thank you for your attention. I hope that is
So thank you, Professor Óscar. That was an excellent talk. And I must mention here that, we as a society, the Obesity Surgery Society of India, we had published in the year 2019 the same guidelines which were published in 2022 by IFSO and ASMBS. So we had got the guidelines down to between 30 and 35 with 2 comorbidities, and beyond 35 without comorbidities for any kind of bariatric or metabolic procedure. But unfortunately, the insurance companies in India still do not recognize that, and they follow the NIH criteria, which is 35 and above and 40 and above without comorbidities. So just asking you, how have you been able to convince the insurance companies in Spain? Have you been able to convince that, or they still follow the NIH criteria?
There are some companies that are open to do obesity surgery, but in the old criteria. It's very, very difficult to convince any politics, any person that has that is the director of a company, of insurance company, that making obesity surgery is inversion or the future of the company, because the money they are spending in that moment will be recovered, avoiding strokes and cardiac problems and trauma problems, because it's not in a short time when this occurs. Unfortunately, in Spain, we have to use the private medicine for most patients out of the old criteria of obesity surgery. Okay.
Okay. So
Antonio,
I was, yeah.
I think Antonio was able to convince a company to perform obesity surgery.
I think, you know, in Spain, as Óscar said, it's going to be it's a different scenario than in India, I imagine. You know, in Spain, you know, all the surgical bariatric procedures are covered by the national health system, you know, in the public system, you know, and they don't care about the new indication. If a doctor indicates some surgery, you know, the system will admit that, on the contrary, in the private sector, not all insurance companies in Spain are covering, you know, bariatric surgery at all. There are some of them, some not, but not even the old indication. I think, you know, in Spain, the insurance company, the private insurance company, some of them are covering, depending of the one-by-one process, you know, depending of the coverage that the patient sign up. It's going to be depending of the contract of every patient. But I think, you know, as you mentioned, you know, this new agreement between IPSO and SMBS regarding the new guidelines is going to be a very important step forward at present time. Mainly taking into account, you know, the medication. You know, we are now, you know, in the same, you know, in the same space, in the same frame that the medication for some patients. So in the near future, going to be a very, I would say, tough issue to compare, you know, what are going to be, you know, some endoscopic procedure plus medication. For example, you know, endoscopic endo sleeve plus medication versus standard sleeve. You know, it's going to be in the near future, going to be a very important topic to deal with. But I think, in my humble opinion, and this step forward by SMBS and IPSO are going to be very important, and it's arrived in the correct time.
Correct. So that's exactly the case here. But the only difference here in India is that almost more than 90% of all bariatric procedures are being done in the private sector. And because they are being done in the private sector, the insurance companies would pretty much work the same way as they would do in Spain. They would look at case by case, or they would look at options where they can refuse bariatric procedures. But still, they've gotten much better in the last 3 years, and we hope in due course, with you know, our association having a constant engagement with them, at least we will convince them to understand that these procedures, these new guidelines, and let's see how it works. But
because because in the end, Dr. Randy, they are going to save money, you know, because they are investing money, as Dr. Óscar said, you know, regarding hip replacement, knee replacement, spine surgery, cardiovascular event. You know, in the end, they are saving money. But the politicians, as you know, guys, they are only seeing, you know, in a very short period of time. You know, they don't have the global view, and they are not thinking, you know, in saving money. They are only thinking in maintaining the power.
100%. So I was looking at all the indications which Professor Óscar has given between 30, 35, and we quite agree with most of them. type 2 diabetes, dyslipidemia, hypertension, sleep apnea, NASH, GERD, and so on. But there are some others, like he showed some data on arrhythmias, and he's written one more as headache. So, I mean, those are some which will maybe at times be a little more debatable, but the others, I think most of us would agree that those are indications for at least some kind of an intervention between that segment of 30 to 35. Yeah, yeah. And again, when we look at hernias, where a lot of hernias are being done in our part of the world, we all agree that up to 30 BMI is something which you can probably do at least comfortably and ensure that there are less chances of recurrence. But anything beyond that, you're absolutely right. It would require metabolic intervention and then probably a hernia surgery, particularly at BMIs more than 35. So I agree over there. But you showed some data on liver transplants, and I was quite surprised. There is a huge mortality which is associated with liver transplants, even though you may do it, together or after, along with the bariatric procedures. Your comments on that? Renal transplants was fine, but liver transplants, there's huge mortality associated.
That's true overall in the liver transplant, but probably it's not due to the bariatric surgery or only the bariatric surgery. It could be a mix of reasons. And in Spain, we are not performing bariatric surgery in patients with liver transplant. Yes, in the case of kidney transplant, that I think that has less problem of relapse of rechazo of immunological problems. The liver has 5-year mortality of 30%, and the data is not from our hospital. The data is from the United States. I don't know. I don't remember the data of Mayo Clinic, but I agree that it's very high, and this is why most of the country doesn't perform obesity surgery, even knowing that is the cause of the cirrhosis that conduce the patient to the liver transplant. This is a question to think twice.
So one last comment before I hand it over to Dr. Kanagwel for the vote of thanks. You talked about robotic surgery. Robotic surgery is something which is now being done in huge numbers here in India as well. And now we have 4 robotic platforms apart from Da Vinci. So we have Da Vinci. We have now an Indian platform as well. So they have made an Indian robot which comes at almost 1/3 the price of the Da Vinci, though not as refined still, but there is work in progress. And we have 2 more systems, one by Medtronic, and there's one by the Cambridge Medical Systems. So we have 4 robotic systems available in India, and most of our centers, including ours, are doing huge volume with the robot. So yeah, I totally agree. That's the future now. And once again, thank you so much, Professor Óscar and Professor Torres, for your comments, your talks. It was very lucid. We've enjoyed it, and I'm sure the audience here have enjoyed it too, all over the world. And now for the official vote of thanks, I hand it over to
Hello, good evening.
my good friend, Dr. Kanagwel, and Dr. Satish, please. Dr. Satish, our honorary secretary, for the vote of thanks, please. Thank you.
Good evening, everybody.
One moment, sir.
Unfortunately-
Dr.
Yeah.
Existing, can you just check on the video of Dr. Mehta, please? Please switch on his video if possible. Yeah, thank you very
Yeah,
much.
So thank you very much, Dr. Professor Antonio Torres and Óscar, for wonderful deliberations on both the topics. So there was a lot of learning for all of us, and revision surgery as well as the new indications. There will be some controversies, and indications will vary from region to region also. So I think we'll have more trials, and then our surgeons here also can try on these patients. So we'll have to convince these patients, and we'll have to have data to do all these surgeries also. So it was a wonderful learning. So thank you very much from all of us, from the surgeons throughout the world. They have listened to you, and it will be available on Facebook and YouTube, and they will keep learning from these presentations. Thank you, Dr. Randeep Vadhavan, for moderating these sessions, Dr. Kanagwel for arranging the show and getting good speakers for us. Thanks the DocPlex team for being part of this educational prime time. Thank you all the listeners. Have a good day, good night. Bye.
Thank you, Dr. Mehta. And I take this opportunity to invite you all for the the annual Congress of the IAGES. IAGES 2024 happens from February 1st to 4th of 2024. And it is going to happen at the Hotel Taj Coromandel of the southern part of India, Chennai. We also warmly extend welcome to Professor Antonio and Professor Óscar to be part of us during the annual deliberations of IAGES at India. And good night, everyone. I personally thank Dr. Vadhavan, Dr. Antonio, and Dr. Óscar for making this event a possibility. Dr. Mehta is always there for supportive as far as program is concerned. Thank you, DocPlex's team. Thank you, friends in India and out of India. Good night. We will
Bye,
meet
good
for
night.
yet another prime time edition. Good night, everyone.
Okay.
Bye-bye.
Thank you.
Bye.
Bye.
Thank you very much.
Bye.
Thank you. Bye-bye.
Thanks.
Thank you.
Óscar, hasta luego. Nos vemos.
Hasta luego. Gracias.